Aortic regurgitation. Etiology, pathophysiology, and pathology. Aortic regurgitation, AR, may result from primary disease of the valve leaflets, dilatation of the aortic root, loss of commissural support or failure of valve prosthesis, either alone or in combination. The result is the addition of a regurgitant volume to the normal inflow from the left atrium. NB. Etiology of AR. Dilatation of the aortic root. Degenerative, senile. Cystic medial necrosis, isolated or associated with Marfan's syndrome. Aortic dissection. Systemic hypertension. Aortitis, connective tissue disorders and syphilis. Primary disease of valve leaflets. Rheumatic heart disease. Infective endocarditis. Bicuspid valve. Myxoma II degeneration with prolapse. Trauma. Loss of support of the aortic valve cusps. High ventricular septal defect. Fallots tetralogy. Failure of a prosthetic valve. Clinical presentation. The patient may present with the following: exertional dyspnea, orthopnoea and paroxysmal nocturnal dyspnea, lethargy, palpitations, angina. Investigations. ECG. Look for the following: normal/left ventricular, LV, hypertrophy, left atrial enlargement, prolongation of PR interval, nonspecific ST segment and T wave changes. Chest radiograph. This is normal or shows cardiomegaly, which may be gross. There is pulmonary edema in acute cases. Look for evidence of aortic dilatation or dissection. Echocardiography. Echocardiography may enable diagnosis of the etiology from the anatomy of the aortic valve and root. Severity assessment is semi-quantitative and derived from color and continuous wave Doppler, Fig. 54. LV dilatation and reduced ejection fraction occur with untreated severe disease. Transesophageal echocardiography may be required to exclude dissection and endocarditis. Coronary angiography. Coronary angiography will be required before surgery to assess the coronary arteries in most cases. The AR can be assessed with an aortogram. Differential diagnosis. Consider pulmonary regurgitation and mitral stenosis with Gram-Steele murmur. Treatment. Emergency. In patients with acute severe AR or severe decompensated chronic AR, treat heart failure aggressively with diuretics, vasodilators, and inotropes. Look for the underlying cause and plan early or emergency valve replacement. Long-term. Patients with asymptomatic mild/moderate AR with normal ventricular function require annual clinical and echocardiographic assessment. Antibiotic prophylaxis is required. All patients with severe symptomatic AR should be considered for surgery. Early surgery is indicated if there is evidence of LV dilatation or LV systolic dysfunction. Patients with coexistent aortic root dilatation greater than 5 cm and AR of any severity should have aortic root reconstruction and valve resuspension or replacement. Complications. Complications commonly encountered include the following: progressive heart failure, mitral regurgitation, atrial fibrillation, sudden death. Prognosis. The risk of developing symptoms and/or LV dysfunction in severe AR with normal LV function is 4% annually. If there is LV dysfunction, the risk is 25% annually. Prognosis is excellent in mild or moderate disease. In symptomatically severe AR, the yearly mortality rate is 10%.